going to talk a little bit about the trailblazing solutions from EBMS that are either here present or just on the horizon, and we're going to welcome them up to the stage, led by Greg Camus, our Chief Health Officer, and we have Rod Kastelitz, Vice President of Sales, Laura Rookusen, Director of Health Risk Management, and Jared Weenham, Director of MyCare and Prescription Services.
They're all coming up together?
Well, they're going to sit, and I believe
Greg's coming up first, isn't he? I wanted to meet him, yeah.
All right.
All right,
Please
here we
welcome
go.
Greg Camus.
Hi, Greg, yeah. Come on back, Greg. Now, Greg, I was really looking forward to meeting you because I understand that within EBMS, you are a visionary, a scholar when it comes to healthcare innovations, a real go-getter, and the person to know in this industry.
Well, I wouldn't say that.
Well, actually, you did say that. I got that information directly from your resume. Now, let's get down to business here. As an HR professional, I have some questions like, what can I do to contain costs to really ensure the well-being of my staff and do it in a way that I don't feel like I need to have a drink at the end of every day?
A drink? Horse? What do horses drink?
It's when you got a 4-gallon bladder like I do, you drink a lot.
Well, so the questions about what are we going to do about healthcare cost containment, those are great questions. And I'd love to kind of get started and give you a little bit of a model and maybe start at the beginning and go from there. And then we'll bring up some of the experts and talk about some of the innovations that are going on. Nathan, does that sound okay to you?
That sounds good. I'm chomping at the bit. Give us a lowdown, would you?
You got it.
I'll get out of the way.
Okay. I probably have control of the slides, don't I? I'm so used to Nathan doing everything, honestly.
It's like that in my life.
Where are we at? Here we go. So we're going to go backwards a little bit to go forwards. In 10 minutes or less, let me draw you a picture. So going backwards to go forwards is when we started with healthcare cost containment for the industry, we really started with managing current risk. And we did that through managing utilization. Primarily, it was around authorizing care based on medical guidelines, what was appropriate and necessary. Then, as a result of that, there were probably some cases that came from the hospital or from an event that needed some specific care and management. And so case management was the next piece. It didn't take long to identify that people with diseases consume significantly more care than anybody else, and so you need something about specifically around disease management, typically 5 categories or 7 categories. That was a great start, but what you have to do ultimately then is you have to go upstream. And so the circle to the far right of your screen is health risk management. And so that was the prospective risk piece. So we really started by managing current utilization and then providing for how do you get upstream to manage prospective risk. And that was the health and wellness stuff. You've heard some of it from Adam and his perspective. You've also heard from Larry about his. And so these were the first 2 sets of kind of overlapping circles about how you're going to start to manage risk. Nathan, are you good with me? Are we good so far?
I'm good.
All right.
What, I got a line here or something?
No, if you want one, you can.
All right. Well, we're talking about the 4 circles?
Yeah.
We already get to that?
We're there.
Oh, well, then let me ask you about that then.
Okay.
All right, I understand this alphabet soup, but it's not really helping me out here. In fact, maybe it's just me, but I'm still at the level of I mean, I'm going, So, are we going to be seeing any more of these dots? Because it looks like a half-completed twister board up there, my friend. Right hand CM, left foot blue. Are you going to show us some more moves there, Greg?
Yeah, well, I'd love to draw you some more circles. I think that we had concentric circles from Jason earlier, and we've had some other models. I think some circles would be good.
If you're into circles, man, it's going to be an interesting game of twister. Go ahead, carry on.
Did you start drinking before the end of the day then today?
No, but I think if I see more of these circles, I might.
That's a deal.
All right, carry on, Greg.
All right, okay. So for me, we start with these core pieces of what the puzzle are, but they're wrapped by a whole series of stuff that's really important to play with. And so the next one up was really benefits. And I'm not just talking about providing benefits, and I'm not talking about rates and copays and what your plan document looks like. I was really thinking more around value-based benefit design. How do you identify some risk and then design your benefits to correspond to that, whether that's minimally invasive procedures as a way to manage cost, or whether that's whether that's value-based benefits where you're waiving a copay to get someone to a specific service, or waiving a copay for a pharmaceutical that they really need and that if they take, and they're more likely to take if it's for free, they'll have a better health outcome. So when I'm thinking that circle that wraps this is that benefit circle, those are things that we have, certainly people in this room that are doing those things, and that you have to be able to support from, as a third-party administrator, support the structure of doing that. Beyond that, then you have to start to, and Larry kind of referred to it, and I'm going to give it a phrase that I would use to describe it. This is about aligned incentives. So this is about the incentives to help people, and it's the carrot or the stick, or in some cases it's the orange painted stick that you use to help people, incent people to behave in a way that produces health and reduces cost. And so these become aligned incentives as part of what I would call a human capital management strategy. And it's bigger than just healthcare management. It comes to the productivity and the absenteeism and productivity and presenteeism, and really it becomes down to the EBITDA level. And so it really becomes about the success and the health of a company as a whole. And so incentives becomes a really important part, and you've got to wrap that around. Beyond that, then, it's about how do you buy your care? And this is the transparency question. And so it's got a place on our model too. Interestingly enough, the models that you saw before, I hadn't seen those. This is ours. And so it's nice to kind of have that verified by these external experts and colleagues. And so this is a really important part too, because it's the first of two steps. One is how do you buy care differently? And then the third one is around how do you deliver care differently? And so whether these, and particularly for post-PPACA, it's about, there is an absence of primary care. There's already a gap in primary care. What are we going to do when we add the other 40 million Americans who don't have primary care into our model? And we have employers in this room who've decided to solve that by putting primary care clinics in their buildings or sharing them with their neighbors. And so this is a really important piece about how do you buy care differently. We'll have experts that come up and talk about how we do that today. The next one is really, the question was begged by ACOs and networks. And so in my past life, I did run care management for a medical group that took risk. And so I know a little bit about this, and this wasn't so much around networks like discounts. This was really more like providers and facilities of distinction. This is about finding the right solution, whether that's agencies or industries of quality that you decide to build into your plan to drive people towards outcomes that we know will cost less money and produce better health. The next layer around that is these are all informed by the analytics. And we're going to talk about a little bit different model in a minute. But the next layer was really truly analytics. And analytics was the definition of how do you convert information from data to information. And we're going to talk more about that. Then there are claims. There are giant claims that happen. How do you manage those claims? And we're going to talk some about that today too. And then finally, it could be that you've done all these things, but you decide that what you want to do in addition is something that you guys might have talked about this morning, which was captives or some form of alternate risk transfer. So this is kind of these are the core circles of my model. And we're going to try to put some of the content and kind of more of the detail on some of these topics on our on our lines of the circle today. We talked generically or generally about how important it is, but let's talk a little bit about the details of doing that. This all sits on a foundation of a couple of things, and I'm sorry, and I would be glad to, I think it's on your slide, on your USB drive, so you'll be able to look at this in detail. The first three stripes are data systems, so you have to have the data, claims, pharmacy, encounter data. That move on to informatics, something to convert the data into information. And then at the next level up is really the applications level. So it becomes consumer tools, and it becomes the predictive modeling, it's uses of the medical guidelines and the electronic health records. And you'll find that these things are also going to be talked about as we talk about our My Health Manager, powered by Dacia, to do some of those things as well. How do we translate that into actionable items for consumers? But also then how do we translate that to inform plan design and benefits and incentives, the selection of networks, and ultimately the management of claims. At the very bottom of this is the EBMS team, where the core strategy are customer service and client strategies. How do we help you use those tools to convert that into something that's actionable for you? Now, the truth is that not everyone uses all of these things, and that not everyone's either ready or their problems aren't the same, and you don't need to use all the same tools in the same way. So this is kind of a once you've done one, you've done one. But the circles are a place where you may decide that you're going to pick and choose which ones line up with what you need today or what you'll need in the future. and how we do that. So, but I want to give you a little bit of a glimpse about some of the things and where they land on those circles in our concentric circle model. Nathan, does that sound fair? Are you up with me?
So far, so good. That's a tantalizing tease. But I understand you got a posse that's going to come up here and help you explain it all, right?
I do.
All right, I'm going to let you bring them up. I'm going to get out of your way. Let's move along.
Fabulous.
Take it away, Greg.
Thanks, Nathan. I'd like to introduce Rod Kastelitz and bring him up and let him turn you loose on some slides.
Thank you, sir. I'm going to try not to offend our friend Nathan, and I don't want him showing up on this screen when I'm up here. We did not rehearse this.
We'll see what we can do about that.
But I don't want to beat a dead horse either.
Oh, brother, you don't want me to comment on that? Come on. Keep moving.
All right, I'll keep moving. But you've heard a lot of views on what's happening out there on these large claims that are taking place. And this is something that is keeping employers up at night, keeping health plans up at night, keeping stop-loss carriers up at night. And it's becoming a huge problem. I think you heard a very passionate Corey Cook. Her heart was twittering when she started talking about these bills. You heard the example of buying a house without knowing the price. I actually heard my friend Woody gave a good analogy this morning. I'd be happy to sell you a car without giving you the price, and I'd be very happy to give you a 99% discount. And that's kind of what's going on out there. But that's what we have. That's what our system is now. So today, just real briefly, I'm just going to talk about some of the things that are going on out there, new strategies, and I wouldn't even call them new. They've been happening for several years, but they're just starting to gain momentum because we're really starting to pay attention to what's going on with these large claims. And they're not getting smaller, they're getting larger. This is a scary fact. I was at a stop-loss carrier conference a few months ago, and I heard that in 2012, there were 2 stop-loss carriers that each had a stop-loss claim that totaled $15 million. One claim each, $15 million. And that is staggering me. I don't even know how that happens. I don't even know how you get to a $15 million claim. But imagine your renewal as a self-funded employer after you have a $15 million claim. And so it's a problem that needs to be addressed. And ACA is not going to address it. Adam said maybe 6 years from now, we might get some new legislation that will address costs. But as it sits right now, we have to be looking at new innovative strategies to get this under control. Our current model is, we have very good PPO partners in this room, and each one of you have different challenges within your plan when it comes to selecting PPO networks. You have geographic challenges, trying to find the best network with the best access, with the best discounts. And it seems like it boils down to, I need to have this provider in my network. And that philosophy is starting to change a little bit. And we're starting to realize that we can't have all the providers and still get the best deal. So the PPO networks are starting to change their philosophies. They're starting to retool what they're doing to come up with narrow networks and get more aggressive discounts. And I think we're going to see that continue to evolve. Another challenge is, as Adam had mentioned in his talk, is with the BUCAs. And the limited ability to audit claims, the limited ability to review claims, because at the end of the day, their client is that provider. And they're going to do everything in their power to protect that provider contract. And so they don't want people meddling around in their auditing claims. They don't want you finding charges that shouldn't be in there. They don't want you to see the excessive stuff that's going on. And so that's an issue as well. Now, coupled with the PPO networks and things like that are the ability to utilize wrap networks. So when your people are traveling or they're in other areas or they have emergency care out of state, they have the ability to utilize wrap networks. And there's many vendors out there that provide that. But in addition to that, there's also the ability to contract with a out-of-network negotiation firm, which we do on your behalf for many of our clients. And again, you're just trying to do everything that you can possibly do to get at those costs so that you're not paying a retail fee. And it can be effective. So, what are some of the new stuff that's taking place out there? Well, some of the new stuff is, you've heard the term cost plus, you've heard the term Medicare plus, and it's starting to become a term that people are talking about quite frequently. And it comes with its challenges. It's not a silver bullet. I don't have a silver bullet to give you. I laid awake all night trying to come up with one to solve the healthcare costs. But there wasn't enough alcohol at the Rex to solve that problem. But there are some innovative things going on out there. And, it just really depends on where you're at and what place you're at with your plan and how aggressive you want to get. These programs, these cost-plus programs that are evolving, and there's vendors in this room that are doing this, and they're doing it very well, and they've had success with it, they can really have an impact on these costs. And at the end of the day, it has an impact on your renewal, it has an impact on your health plan. We've been talking about Medicare Plus, and there's people around the country that have been doing it for a long time, and the biggest fear that everybody has is, yeah, it sounds great, but what happens when my member gets balance billed? That's the HR person's biggest fear. They have people sitting in their office, they have a $100,000 bill sitting there, and their person is getting billed for it, and they don't know what to tell them. So over time here, these programs have evolved. You heard some folks talk earlier about putting in language in your plan document, making these vendors become co-fiduciaries where they're actually setting this up to defend you so you can defend yourself if a hospital ever comes back against you or comes back against your member. And they're doing a very good job of this, and they're having great success. Another big factor is providing that support to your members. Okay? In order for you to implement a very aggressive pricing program like this, you need to have support for your members, and you also need to have legal support for them. Another concern is the whole collections thing. How does this affect the credit rating of my members? These programs are evolving, and you're hearing new companies coming out with this every day. It's going to become a new term we're going to hear a lot about because we need to do something with these high-cost claims. And I think if you're very interested in one of these, I think it's something to take into consideration. I will warn you, though. You can't go into these part way. You can't just tiptoe into this, if you will, because you have to stand firm. Okay? But if you have the proper education for your employees, you have the buy-in from the top executive team at an employer and the broker, and you have the proper language in your plan document and all the documentation that's needed, you can really have an impact on these large hospital claims and really have an impact on the future of your health plan and continue to offer competitive benefits for your employees.
Thanks. So it sounds like, waiting for my mic. Okay. So it sounds like there's some prospective stuff to do, as well as some stuff that you might be able to do as a reaction. So it sounds like it's a multifaceted problem, takes a multifaceted solution. Thanks, Ron. So the next one is, so we're working from the outside, Rod. We're working from the outside in. We started at captives and claims management. We're going to come back down to care delivery and transparency. And to address some of those things, I'd like to bring up Jared Wienums. Jared's the director of the My Care clinics and the MyRx pharmacy. Jared.
All right. Well, good afternoon, everyone. We've been talking about healthcare reform all day today, and I'm going to talk for a few moments about on-site clinics. And the nice thing about that is this offers more affordability, more control over your health plan than anything else that we really have in our arsenal at the moment. So there's no fine print, there's no red tape to this. This is really making a simple and efficient system that saves money and increases health. So let's talk a little bit about what that looks like, or what it would look like if we implemented such a thing for you in your office or your workspace. Today we're talking on-site clinics. For some companies, it's near-site clinics, so something that's 5 10 minutes away that your employees can access, their dependents can access, they can get in there and they can make an appointment. Now, under the MyCare model, what we do is all of the services that are provided at that clinic are completely free. So those services, there's no charge to them. We're talking the office visits, we're talking labs, we're talking prescriptions, office procedures, anything that's done in those walls in that clinic, no charge to the members. Very appealing to the members as well. Our goal here is really to increase utilization and access to primary care. If we can do that, we can drive a lot of those claims to the primary care center. We can save money. We can save money a couple different ways, but we're building a healthier, more productive population that in the long term is going to be healthier and have less claims expenditures. You know, there's some stats out there. It's about 85+% of all the care that we need as individual patients typically can be done in a primary care setting. So implementing a benefit like this is such a huge benefit because, again, 85+% of the care that you need as a patient can be done at that on-site clinic, and it's free to you as that patient or as that health plan member. MyCare really does serve as that medical home, owning the process, being accountable, integrating the care, working with the patients, following up with the patients, making referrals out to specialists, but bringing that care back home to MyCare for further care and further follow-up. So let's talk a little bit about the model, and there's some financial components to this, but the first thing we want to talk about are the traditional barriers. The traditional barriers to healthcare oftentimes are its cost and how incredibly inconvenient or how much time it takes. So like I mentioned before, all the services here are free, but the convenience factor is incredible in this model. We've all been to the doctor's office appointment. What do you have to do? Well, the first thing that you typically have to do is you have to call your employer and let them know you're probably going to need a half day off from work because you're going to the doctor. You drive across town, you go to that doctor's office visit, and you go to the waiting room. That's right, the waiting room. To do what? Wait. Finally, a nurse comes, gets you, takes you back to the exam room this time to do more of what? Wait. National statistic or national average, about 5 to 7 minutes of actual time is spent with the doctor. That doctor's back out the door, and the nurse is back in, probably handing you a prescription that you now have to take and get filled. In this model, incredibly convenient, you schedule the appointment online or via a toll-free number. Your appointment is a full 20 minutes, so that means you have 20 minutes with that provider. Not the 5 to 7 minute average, 20 minutes. If you need more time, take 2 back-to-back appointments and have 40 minutes with the provider. Our average wait time is less than 2 minutes. We have a waiting room that we actually call reception room because everyone laughs. They come in and pick up their People magazine, and before they can even open to the first page, we're pulling them back to the exam room. So incredibly efficient, incredibly convenient. So what we're trying to do here is really transform the paradigm of this model from a fee-for-service to the true cost benefit. So what we're doing is we're purchasing healthcare on that wholesale basis. And by increasing the care utilization, by working with those patients, building healthier patients, they have lower health risks. They also have lower health expenditures in the future. So you save money through those 2 primary means. The MyCare clinic is staffed and managed by MyCare. And for some states, this is really important. There's 26 states out there that have a corporate practice of medicine law in the books, and it really regulates who can have ownership and who can have say in on-site clinics. But that's why MyCare is here, is to manage and keep the client at arm's length distance from the clinic and make sure that you're managing it with that clinical and business perspective. The clinic hours are simple. They're tailored to the needs of each individual employer and their dependents. We typically staff 50% of the time with doctor coverage, the other 50% of the time with mid-level coverage. Again, from a cost perspective, that helps save some money. And the provider's managed with a wellness focus that's tied to evidence-based medicine. There's no hidden agenda. They don't have to work up so many patients per day. They don't have to make so many referrals to the new imaging center down the street. They get to come in and just practice medicine and do what makes sense for the patient, both from a clinical perspective and the financial perspective. All of this in the MyCare model is supported with extensive reporting, consultation, integrated report packages, and a master communication plan that can also be encompassing of any disease management programs, wellness programs, those types of things that oftentimes many health plans are having. Let me tell you something else. If you're talking wellness, you're talking disease management, who has the most impact in getting someone to change or the most influence? It's their provider. We want to build that relationship, and that message needs to come from the MyCare clinic, from the provider. So integration is key. The other thing that the model enables is, for the first time, the providers, the health plan, and the employer are all working in tandem. They all know what each other are doing. It's the left hand knowing what the right hand is doing. So the providers know how much these services cost. The providers know that when they need to make a referral out for an x-ray, they know how much your health plan costs. It helps them make educated decisions and engage that patient. Integrated clinical and claims data, we've been talking about this as well today too. The more data that you have that you can make actionable, you're going to see results. Monitoring gaps in care, providing that actionable data back, making targeted efforts towards, let's say, diabetes, high blood pressure, high cholesterol, all of those things. But again, we only want to do that to those patients that have those specific conditions or those patients that are at risk. And we're going to be more impactful that way. And again, all of this can be done under one communication platform that integrates that primary care with disease management and wellness. So let's talk about the dollars of cents of it, because this is where many of you wonder, how does it work? How does it work for my organization? Typically, we're seeing break even on these clinics after 1 year. Every one of the clinics that we've implemented has been incredibly successful, both from a standpoint of value for the patients, for the members, but also from the financial perspective. Average ROI, 1.5 to 1, up to 3 to 1. Now that's average. We see ROI 7 to 1, 8 to 1, so there's definitely an ROI there. The average cost for this service, all in, all inclusive, all supplies, all malpractice insurance, all provider salaries, all in, $50 to $75 per employee per month. Now keep in mind, you're spending $50 to $75 per employee per month on an on-site clinic, but you should also be seeing those costs dropping on the health plan side as we're converting those services over to the clinic. There's obviously soft dollar savings, there's retention, recruitment, all kinds of different benefits that are hard to quantify and put a true savings to, but there's definitely a lot of benefits there. The beauty of this is it's concierge medicine that actually costs less. I know that seems hard to believe, but concierge medicine that is going to cost the health plan and the employee, the patient, less money. So as you look at these models, just make sure that they have a business side to them, because the business side is what is helping really reinforce and making sure that this model is feasible and that you can sustain it. Now, the same thing can be said, and I'm not going to spend hardly any time on this, but we learned about how much markup and margin was in prescriptions when we first started doing on-site clinics. And it led us to develop our MyRx mail order program. So for those clients that maybe can't put in an on-site clinic, we do have a mail order MyRx program that is the ingredient cost of the drug plus a dispensing fee. Again, we're taking out the margin, we're taking out the markup, we're taking out the inefficiency, and delivering that same quality service for a lot lower cost. So, with that said, again, there's a lot of opportunities for that, and we're definitely happy to talk with you more specifically about each of your groups and what may work for your groups as well. So, thank you.
It really becomes like a primary care medical home, and it's done on a cost-plus basis.
So you can imagine that buying care wholesale and ROI is pretty easy to calculate on that. And I think the part that was is always remarkable is then the amount of time people save and the presenteeism and absenteeism that goes away as a result of just being able to walk down the hall and go to a clinic right on site. So.
Actually, I hate to do this. I always do this. But there's just one more stat to talk about that really talks about the savings.
Nathan?
This is quick, I promise. But you guys really will understand how quickly you can save money in an on-site clinic. Let me give you an example. We do annual health risk assessments through the clinic. So it's a 28-panel CBC, CMP, lipid panel done through the clinic. The cost of that, if you went out in the retail market, $120, $140, even more in a lot of areas. The cost through MyCare, $7.75. The cost to the patient, obviously zero. So you can very quickly see how much markup and margin is on that one service. And again, it's that way throughout all of the services of MyCare. So, thank you.
Yeah,
Thanks. So we started at claims management and the captive layer, and we went down to transparency and delivery.
and the next stop down is really back to health risk management and how we start to connect some of these pieces. So I'd like to bring up Laura Rookhausen, who's our Director of Health Risk Management and Director of CareLink, and invite her to share some of the innovations that are going on now. Thanks.
Hi, welcome. Thank you guys for being here. As Greg said, and he pronounced my last name right, so thank you. Kudos to you. There's just a few vowels in there, so thanks for getting it right. I want to talk to you today a little bit about connecting patients and providers. Easy, right? Providers are this small captive audience out there. Not a problem. Yeah, it's an absolute nightmare. And so what we have done is put together a partnership with a fabulous vendor. And I'd like to ask Stephen Chapkin to stand up if he would, so that all of you can remember his face for later on tonight to network with later. So thanks, Steve. Steve's with Dacia, and they are really the foundation and the framework behind the platform that we put together. The platform it would take me hours and hours up here to go through all the different features and functionality, and so I hope you'll take time to connect with one of us later on to get to know a little bit more about those or your account managers. But for the purpose of this, let's talk about that, the relationship between the two. So why is a relationship between a provider and a patient important? I have up here the MyCare logo, as Jared just talked about. We have a captive audience with our MyCare providers, and it makes this a lot easier. But I think as healthcare transforms and changes with all of the things that Larry and Corey and Adam talked about earlier, I'm hopeful that this will expand outside of on-site clinics. But for right now, we're going to focus on this area with our clinics. So again, why is it important? Well, we don't want duplication of efforts for our patients. As we all know, tests and different various screenings are costly, as we heard so passionately from Corey earlier, and they also can have certain side effects and risks for patients, so we want to make sure that those are not being abused. And furthermore, we have general practitioners, which are absolutely fabulous, and then we have some patients who need specialists and need that multifaceted care approach, and we need the provider A to know what provider B and C is doing, and so this is important as well. And then also, those of us in the room, I don't need to give you the reason why, but it's important for prescriptions. Obviously, there's interactions and things of that nature that we need to talk through. So we at EBMS said, what are we going to do about this? We're an innovative company. We have to do something to help our clients. And so as somebody mentioned earlier, I think it was Adam, his own employees are his guinea pigs for everything, as are EBMS employees. And so we have been piloting this platform, and we recently rolled Emeritus onto the platform as of June 1st, and we're getting ready to roll a bunch of other clients on throughout the rest of the year and beginning into next. So I'm sure you'll be hearing from your account managers. But this is just a snapshot of what the platform looks like, what we're doing with it. It really is a personal health record, and we want to be able to aggregate everything in one place for our members. So I wanted to tell you a little story to illustrate this, just from this, again, patient and provider perspective. So this is Paige. Paige is an individual. She has spina bifida. She is a child. Her mother obviously is a policyholder of a plan. And she sees multiple specialists in multiple cities and multiple states. And she has multiple tests that can have impacts on her life in terms of multiple x-rays for getting lots of radiation, things of that nature. Also, as the policyholder, the mom knows that she has costs associated with each one of those tests as she has a high deductible health plan. So obviously wanting to get Paige the least amount of radiation and associated risks with the highest quality of care, she adopted the My Health Manager dossier record. And this is an actual story. She does live in the state of Montana in a rural region, so this was powerful for her. She took the initiative, she worked with providers, and she has actually uploaded all of Paige's information. As you can see here, I have the X-ray app, but there's also all the associated radiological reports, things of that nature, that specialists in Denver and Seattle and things that where she takes her daughter to would have access to. So Mom and Paige travel, they sit in the doctor's office, they pull this information up, no duplication of tests are needed. It's a very powerful tool that, again, it's hard for me to just talk about one little tiny segment of it. I want to tell you all about it. There's multiple other features, but I hope you'll see that this is one way where we can reduce costs for this individual member, ultimately for the plan, and ultimately impact the health of this little one. That obviously is the most important at the end of the day. So with that, the only other thing I wanted to leave you with was the power of the tool outside of that patient-provider relationship. This is just a sample of one of the reports that, as a member or a user of the portal, that you would see upon completing a questionnaire, health risk assessment. But there's also a lot of other data in here that we're able to aggregate with the power of the tool and really pull a holistic view together for that member and basically serve to them on a silver platter. Here's a snapshot of your health, whether it would be to work with a health coach on their own or take it to their provider and develop that plan of care that would be appropriate. Whatever the next step would be, the platform's there and ready to do that. So with that, Greg, I'll hand it back over to you.
Thanks, Laura.
Yeah, the tool is really cool. It's almost Facebookish in its layout. It has applications for consumer decision making. There's places to put or to send clinical data onto your site. So when you log on, you can access your data. You can friend your providers so they can text you or email you. There's a back-end tool that's being built right now to be able to facilitate the kind of wellness program, incentive programs, or push out challenges based on the risks and the scores of the entire population at your employers. So it's a pretty cool tool. We wanted to highlight the provider-patient piece as we talked about innovations in healthcare quality and cost containment. But it's a system that's truly enabled for a lot more than that. So we talked about all these things. We started with the core, current and prospective risk management. We walked up in terms of building a model. We started at the content at the outside and walked back down, and so we're back to the core. There's been some enhancements that we've done to the core this year, and we now have fully accredited, URAC accredited programs for utilization management, for case management, for disease management. We've extended the service hours. We've added a specialist model for the nurses. So we've added pediatric and oncologist nurses and psych nurses to our profile. We have upgraded the disease management program to be a true clinical disease management program, and through our partnership with American Health Holdings. And so we're really proud to have our nurses on their platform delivering services for your members. And the art of what we were really good at is still right there. And so we're thrilled to have done that as an upgrade. As we really looked at and using the data that we have and the analytics that we applied to that data to turn it into information, and with partners and great vendors that we have, we identified that there was another need, and I want to talk about that. Outside of that current utilization management of how do you manage current requests for care and medical necessity and appropriateness, and how do you manage a case when it comes up and there's a hospitalization or something that might have an extenuating need, there's a group to the far right or left of that, that I want to talk about as a program development and something that we're in the process of doing. And And really it's about a population that is at the very top of any population driving risk. So I'd like to walk you through the problem, how we know what we're building, and how it might make a difference. The premise, of course, is that it's the 80-20 rule. It's 20% of the cause has 80% of the effect everywhere you go. And so in healthcare, there's evidence that says 5% of a population drives 50% of the cost. And actually, this is the 5%, the top 5% thing. It's kind of trademarked, or there's a vendor that uses that. And the truth is, in 1977, it was part of a medical expenditure panel survey. So it's an idea and a phrase that's been around for a long time. So I'm not stepping on anybody's toes when I say top 5% program. In health plans, so this is non-institutionalized citizens. When you look at people that actually have their care paid for partially by employer plans, it typically is more like 560. So it's the 560 program. The 80-20 program sounds better. The 5% program sounded even better. I'll come back to that idea. 5% of a population driving 50% of the cost. It looked like this. 1% of the population drove 20% of the cost. The top 5, 50% of the cost. The top 50, 97% of the cost. 50% of your population costing 3%. And this is from that medical expenditure panel survey. This was pretty recent. This was 2011 data, 9 and 10 data. To give you an idea, and I apologize, $90,000 at that top 1%. This is non-institutionalized citizens. Some have health plans, some don't. At the bottom of that, the bottom 50%, $236 was their actual expenditure. Huge disparities. So if you've got 5% of your population driving 50% of your cost, well, who are these people? And what's driving why? What's going on? And so we thought it's because they have diseases. It's a disease management program. That's really the problem here. That's what we have to do. We have to address, we know the people that have diseases have more expenditures than people that don't. When we looked at the distribution, you'll see that there is some disease-specific cost at the bottom, some pharmacy-related cost at the top, but the big part of that was about people that had more than one condition or had something complex going on. So it wasn't just the specific disease cost or the specific disease med cost, it was something else going on. And so we took our data and put it into an analytics system and looked at our population, your populations, all combined. And so what we found was that we also, in that process, would miss some people. And this is a slide that I borrowed from DataSmart Solutions. And they identify, not only are those people, you can identify the top 5% of a people because you can look at their cost. But how do you know who's going to be in it next year? And so this is a really good question. And so it's that combination of the emerging risk and the current risk that should equal the top 5% and would really drive a predictive model using informatics to identify who should be in that population. Well, let's talk about who's there. Some are identified using the total cost. Some are identified using prospective risk. Now, the truth is that some have chronic disease. Some don't have any. Some people in your top 5% don't have a chronic illness. Some have lots. Some have had a really complicated event. It was a trauma or a car accident or who knows what. Others haven't. Well, who are these people? And the answer is that they are the people that have 17 providers and they're on 11 meds. This is our data. They have 19 tests. And from a risk score, you may have seen a risk score either through our OptumIngenix tool or through some of the other tools that we're using. They have a risk score of 5 to 15 times what is normal. These are people that are truly in, there's somebody else's phrase that we would describe as in the medical ditch. These are the people that truly have a specific need that is far beyond. And so it's not just a single event they need managed, they need something bigger. Something else is going on. And so we're building a program to do that. And we've got it all centered. It's so nice. Huh. Okay. So the identification of those using current and prospective risks, models being claims and biometric values, and it creates the highest risk group of clinical management. And it's kind of a concierge case management approach. And it's an integrated team. And it's going to have a nurse as its quarterback. And it's going to have, as part of its team, a social worker, a pharmacist, and a physician. The social worker, because it's not just about the individual that's in this medical ditch, it's about their entire family. It's a pharmacist because they've got 11 meds. I don't want to ask anybody to raise their hand, but that's a lot. I don't know if you've ever taken more than one at a time. Adam? Adam's got it. Nathan, have you taken more than one at a time?
Not in one particular session, no.
That's good to know. Appreciate that. So we have a nurse, we have a clinical pharmacist, we have a social worker, and the last piece that you need is someone that can actually have a doctor-to-doctor conversation. Whether this is about a specialist or it's a primary care doc, or it could be a hospitalist, an inpatient specialist, that you need to have a doc-to-doc conversation with. And so we've built a team, a model that has the nurse as the quarterback, and then some portion of a pharmacist, a social worker, and a physician to do that. And you have to address the specific needs for each patient and family. The premise is you have to improve cost and outcomes. And the truth is, at the very bottom there, the bullet says, I need a cool name. I don't have a cool name. The top 5, top tier. If you got any suggestions, let me know. But I need a cool name. So I have a program need, I need a cool name. Anybody? This will go better if you guys play along, I promise. I know it's ditch diggers. I know it's 4:15 and we're getting really close, but I wanted to share this with you. The ditch diggers, I love that. The wrench turners. Yeah, absolutely. All right. So we're tracking ER visits, inpatient days, amount of unique meds, how many providers they have. Because the goal would be to help people step away, have those problems resolved, and move on. Come out of the ditch. Diagnostic tests, what their risk scores are, and really migrate out of that target population. And then ultimately, we're looking at changes in costs. How do we do that? And so we're in the process of building this program. We have some really great employer partners that we're going to start maybe with them. It's not a test of a concept. We know this works. It's really more about what's the right grouping of services for improving its delivery. And so that's really the process is we'll start with a small group and we'll start there and be able to expand it to everybody. So we're excited next year at this time to talk about maybe the summary of what we found so far doing this as we do that. So for us, we have our core programs and we've enhanced them significantly this year. We're adding what is the top tier or the top percentage as a case management or as a concierge case management solution. We've added the health risk management platform and tools that will let us not only drive people as consumers, but engage them, patient and doctors. We've improved the delivery of care by providing it on-site and transparently. We have innovations and integrated approaches to managing claims and costs, and it's wrapped ultimately by, if you're interested, alternate risk transfers and how do you fund plans and programs. So you've gotten at least a 6-minute glimpse of 4 or 5 things to talk about innovations and what the future or the pioneering of healthcare cost containment is today. Nathan, did I miss anything for you?
I think you pretty much covered it here. Besides, Jared kind of ate up most of your time there. You got a fine posse there.
Fabulous. So our model at the end really is a set of concentric circles that wrapped around some core pieces of healthcare cost containment, and it sits on those foundations of data systems, informatics that translate data into information, and ultimately give you applications, and some through the My Health Manager to start to do that. And it sits on the foundation of customer service and the culture of our customer service and client strategies. So thanks for your time.
I love it. All right. Thank you. Give it up for Greg, Laura, Jared, and Rod.